bringing up our first speaker, Dr. Howard Sesso, who is an associate epidemiologist at the Division of Preventive Medicine at Brigham and Women's Hospital, associate professor of medicine at Harvard Medical School, and associate professor of epidemiology at Howard T.H. Chan School of Public Health. He designs and conducts randomized clinical trials focusing on dietary supplements, nutrition, and lifestyle factors to prevent cardiovascular disease, hypertension, cancer, and other age-related outcomes, which we're all going to need pretty soon. Dr. Sesso is the director of the Nutrition and Supplement Research at the Osher Center for Integrative Health. He has been involved in several major clinical trials at the Division of Preventive Medicine, helping lead the Physician's Health Study, conducting several ancillary studies in the vitamin D and omega-3 trial, and co-leading the Cosmos study, cocoa supplement, and multivitamin outcomes. He's obviously extensively published. Now, when I think of dietary supplements, Dr. Sesso, I think of a couple of decades ago when I heard Dr. Dean Edell on the radio to his audience, telling his audience that my father sold supplements to put me through medical school. But taking supplements, all you're doing is making expensive pee. So how far have we come along? Let's find out. Please welcome Dr. Sesso, coming all the way from Boston.
Well, first and foremost, it's a pleasure to be here this morning. Thank you for that kind introduction, Dr. Khan. Dietary supplements are an interesting topic. Before I even introduce myself a little bit more further, I'm just curious for a quick show of hands. I'm not going to ask anyone to call out what they might or might not be taking. Just a quick show of hands. How many people are taking dietary supplements in any way, shape, or form? Okay, so we'll call this a quick survey. Clearly, a lot of you are. And of course, when you think about that in your patient populations, you're going to see a similar show of hands. And so a lot of what happens is that people are taking things, we're all taking these things, without really knowing what the short and the long-term effects are. So as you heard, my perspective has kind of evolved over the years. My training is a mix of epidemiology, cardiovascular disease, nutrition, lifestyle, and also biomarkers. And so all of this is kind of rolled together into what's become a very strong interest in the role of dietary supplements. Now, one thing that's interesting about dietary supplements in terms of doing research in it is that it's very hard to do research strictly through the NIH. So a lot of times the larger trials in particular that we do are often done in conjunction with dietary supplement companies, because we need them to either provide the pills or the packaging, the bottles, et cetera, or to help support some of the trials and the work that's done too. And that's a conundrum, right? Think about it. If you're producing supplements these days, as you'll see, you don't necessarily have to do a lot of research to back it in the same way as if you're taking metformin, the GLP-1s, et cetera. And so because of those thresholds being lower, it puts the dietary supplement space in a much more precarious position in terms of being able to demonstrate any degree of benefit or perhaps harm. So I just want to start with a concept, which is that when we think of prevention, prevention is something that happens across the life course. This is something that's not just about increasing life expectancy. It's about living longer, living better, enriching those years. There's a lot of terms that are now coined these days about it's geroscience, it's health span. They're all kind of getting at the same thing. It's one thing to say you hit the age of 80. It's another thing to say you've hit the age of 80 and you're still as functional as you want to be at that age. And so this is not just about preventing chronic disease. This is not just about cardiovascular disease. It's thinking about brain health and wellness and quality of life in different capacities. It should start young, as early as the prenatal period. It goes throughout our life. And yet, most of the research that I've even been involved in as well is usually focused on kind of middle-aged and older. So I want to start with the simple idea that when we think about food and dietary supplements, and this is deliberately small print, it's not because it's still early in the morning, right? Diet's complicated. Diet and food is cultural, right? Think about it as a child, family dinners, other foods that you eat traditionally around holidays. So food, nutrition is complicated. Then thinking about the individual components, and this is from a Scientific American article where we put together all these different nutrients and how they work together, how they interact with other nutrients, and how they might be linked with different outcomes. It is really hard to disentangle all this. And so on certain levels, when you think about nutrition, of course, a healthy diet, healthy dietary pattern is still sacrosanct. But at the same time, this is where dietary supplements have a very unique perspective in this because it allows one to be perhaps a little bit more focused. Now, in contrast to the diet being so diverse, we also have to think about what I call dietary reductionism. And this has both a positive and a negative connotation, honestly. But the idea behind dietary supplementation more often than not is, can it somehow capture food's health benefits? And I've done a lot of work in what we call nutritional epidemiology, so studies such as the Nurses' Health Study, health professionals' follow-up studies, these very large-scale, long-term observational studies in which we look at dietary factors and patterns and how they link with health outcomes. Incredibly important studies. They add a lot of value to the field, but there are still limitations with those types of studies because we kind of figure out the foods and the patterns, but don't really know whether the causal role is actually there. And we also don't know what's driving it. Is it specific vitamins, minerals, or what I call bioactives? The essential vitamins and minerals are a part of the equation, but not the only nutrients out there. And I should have made this more red, but if you look at a simple strawberry, some people look at the strawberry and say it must be something healthy about the food, right? So it's the fiber, the vitamin C, and all the constituents that make nature's strawberry that work together in some wondrous way to exert benefits. No different than there are the people that would argue that maybe it's something specific. Maybe it is the vitamin C content or something, or the fiber content or something in that's driving the health benefits. Or it could just be that if I'm eating strawberries, I'm also eating blueberries and other healthy, like rich, colorful diet, and that might be driving the benefits. Or it just might be the simple fact that I'm exercising more and I'm more health conscious, and so it's not the strawberry per se. So this is where dietary reductionism gets tricky because is it the strawberry or should we be isolating the compounds? So just to take a step back, one thing that people don't realize is when you look at any dietary supplement on a store shelf or online or wherever you might look for them, they're regulated to some extent by what's called the Dietary Supplement Health and Education Act, or DSHEA. This is now more than 3 decades old. It has not been modified for 3+ decades, for better or for worse. There's been many instances in which there's been talk about it, but it has not happened at this point. This helped to establish at the National Institutes of Health something called the Office of Dietary Supplements. And their job is to, quote unquote, promote the scientific study of dietary supplements for maintaining health and preventing chronic disease and other health-related conditions. Fair. Where it gets interesting in the DSHEA Act is how they start to define dietary supplements. It's basically something that is intended to supplement the diet. It's taken by mouth. Although there's some debate about if sometimes some of the things you can get, IVs are becoming, that's much more popular form of delivery of some nutritional interventions too. But it includes not just the essential vitamins and minerals, it's anything you can think of. And it could be tablets, capsules, soft gels, liquids, powders, any form. There was a pseudo-regulatory framework that was put around this that's overseen by the US FDA. And there are different types of claims that can be put forth around either the nutrient content, the structure function, or what we would call qualified health claims. These qualified health claims are honestly quite silly. If you look at a product, no matter what they say, you'll still see in this blue box at the bottom, this statement has not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. Why the heck are you taking it in the first place then? Now, it's not to say that these things don't work or they do work. It's just that there's the threshold, the research, it's not like a prescription medication has to go through the different phases of the FDA process for approvals. Supplements essentially bypass that. And so it's created a very interesting environment for sales and use of dietary supplements in the United States. And it puts us in a very tricky position as providers or as patients or as individuals, as I saw the hands up before. Why am I taking it? What is it doing? And am I actually benefiting from it? So, I think a lot of times people look at what I would call the proverbial brown bag when you ask patients to come in with their medications and other things that they're taking. A lot of people look at that brown bag and just see money being thrown away, as was alluded to. And there's been a lot of people who have made very strong arguments in that regard to say that a lot of these supplements are just a waste of money. You take them in and they just get peed out, pooped out, whatever. We just don't know. The simple fact is that we just don't know what they do. And there's been the amount of research relative to the amount of supplement use that's out there is a very big disconnect. What we do know is, on average, from other work that I and our group have done, is that people who tend to take dietary supplements, on one hand, tend to be a little bit more health conscious, perhaps not surprising. But on the other hand, they might have more comorbidities, other conditions. They've started taking other medications that might have made them think about things that they should be doing to either further supplement or improve their health in some way, without necessarily appreciating even some of the interactions that could happen between the supplements that are taken and medications and other things too. So just to offer a quick snapshot about just how prevalent dietary supplement use is, at least in the United States, this is from national data. If you look on the left panel, you can see that overall about 60% or so of US adults are taking a dietary supplement. I couldn't count that quick when your hands are up, but it seems like we are either at that or maybe even a little bit higher. It's higher in women than men. The most common dietary supplement used by far are what we'd call a multivitamin, multimineral supplement. I'll talk a little bit more about that with some of the research I've been involved in. But it's obviously not all of it. And then, not surprisingly, perhaps, it increases with age. So as we get older, supplement use increases for the reasons that I had mentioned before. Now, this is an older range of years, but if you were to extend this out through at least the early 2020s, despite the fact that certain supplements kind of come and go with popularity, the persistence of dietary supplement use has remained remarkably resilient over the course of several decades now. The only other recent uptick was at the early stages of the COVID-19 pandemic. Certain supplements were flying off the shelves on the promise of improving immune health without much data to show that. And then as the pandemic had calmed down, those sales kind of came back down to the usual static levels that we would see here. So one other thing I just want to highlight, and this is true not just in the context of dietary supplements, but more broadly in the context of clinical trials, are just two concepts. I don't want to get too technical on it, but this concept of what we call efficacy versus effectiveness. One of the unique advantages of randomized clinical trials, especially for dietary supplements, is that you can actually have what we would call placebo control. And so because of that, through randomization, ideally when you do these trials, you would develop what we call efficacy. And what I mean by that is that when you are randomized into a study, and let's say we take this half of the room, you're going to take a certain supplement, this half of the room, we're going to take a placebo, or you can't tell the difference. The idea is that if you're assigned to it, you're going to take it, and you're going to stick to the rules on it. Not going to stop, not going to lose you to follow-up. So ideally, when we're doing these trials, and this is where dietary supplements should be more amenable to these types of things, you've got the ability to actually eliminate what we call confounding and look at some of the true causal effects of these supplements on health outcomes. This is why I got into this area of research. With my nutrition interest, as well as dietary supplements for randomized clinical trials, this is a good way to really test convincingly whether these things do or do not work. But of course, in the real world, people start to take things and they think otherwise. I'm feeling a little, maybe it's a side effect, or I don't think it's working, or maybe I think I need to take more. So these trials provide not just the ideal circumstances of what we call efficacy, but also what we call effectiveness. So if you only take the people who are taking a particular supplement, or even a drug for that matter. We can look at the effectiveness of it. But of course, with the nuance that you've eliminated the strength of why we do trials in the first place, which is through randomization, you can get a much more causal look at a question. What's funny is that the media does not care about the way you design your study. I've seen this time and time again. If you look at dietary supplements, this has been a really good example of it. There's been a lot of, I mean, these are good studies, but when you get away from the randomized clinical trials and from some of the observational studies, or sometimes they're called real-world evidence or real-world data, those studies will come out. The media does not pay any attention to it. And so from the consumer standpoint, patient standpoint, it's very hard, it's almost impossible to distinguish or differentiate what's a better study versus a not as good study. Ideally, clinical trials are the source of that, but again, there's no structure in place in the same way as prescription medications for dietary supplements to get the fair testing, the fair shake that they would get otherwise. Now, what's interesting about dietary supplements is that historically, there have been kind of what I would call the supplements of the decade. This is going back to the 1980s, so for those of us able to remember these times, beta-carotene for a long time was a very popular dietary supplement. There's some work that was done for cancer and cardiovascular disease, and through some of the work that our group has done, in particular the physician's health study, the women's health study, and the women's antioxidant cardiovascular study. These are 3 trials that totaled about 60,000 men and women around the US, showing convincingly that taking a dietary supplement with beta-carotene doesn't do anything. So that was kind of the dietary supplement of the 80s, if you will. The dietary supplement of the 1990s, was vitamin E. Lots of trials were done in this space, including our own group with, at the bottom of this list, the Women's Health Study and the Physician's Health Study 2 trial. Again, there were some more interesting signals here and there for some potential benefits, but resoundingly after these trials were done, it was shown that after a lot of interest and spiked supplement sales, that these things did not work, at least for the chronic disease endpoints that we care about. Then we got to the 2000s, and then it was what I would call, in some ways, kind of the vitamin D decade, if that makes sense. Vitamin D was a more interesting case from a dietary supplementation perspective because there are unique risk factors for vitamin D status. It's latitude, it's avoidance of the sun, skin pigmentation, and we know that there were steep age gradations with measuring 25-hydroxy-D levels. And certainly enough, as there was a lot of observational evidence that emerged regarding vitamin D, not just on cardiovascular disease, but on cancer, hypertension. It gets to the point with some of these supplements that you think is somehow good for everything. And these are never panaceas for everything, to be clear. But there weren't enough randomized clinical trials to really show tried and true whether these things work. And so one of the trials that our group conducted starting in the around 2010 was the VITAL trial, the vitamin D and omega-3 trial. This was a trial of nearly 26,000 middle-aged and older men and women around the US, and they were randomized to take either 2,000 IUs per day of vitamin D, and we also tested omega-3 fatty acids. And I'll have a brief comment on that in a moment. This was a 5-year trial, so one thing I did not take with me, and I should have, is that it's a unique person, and we've been very fortunate over the last few decades to have participants that are willing to basically be taking these pills without knowing what they're taking for a very long a period of time to enhance the science and the meaning of these studies, and they don't know what they're taking. I can't tell you how many times we get calls from patients saying, can you please tell me what I'm taking? And we persistently say, we'd love to, but we can't unless you decide to stop, and hopefully you won't. But these are unique trials in that you can get much more definitive answers. So these are the main results for the vitamin D component of the VITAL trial. And it shows fairly convincingly that for cancer, which was one of the primary endpoints, there was no effect of taking 2,000 IUs per day of vitamin D on not just cancer overall, but also cardiovascular disease. Now, where it gets a little bit more interesting, like any other study, is that, and this is more of a trialist type of conundrum, is that we design these trials with one outcome in mind, but in truth, we're looking at many different outcomes. And I would argue that with dietary supplementation, the idea that if everyone here in this room is going to take vitamin D or omega-3 fatty acids and they're going to benefit from it, I think that's wishful thinking. We know that with nutrition, appreciating the complexity of the diet as well as different outcomes that it might have an impact on, it's a much more nuanced answer. It's a sort of a precision nutrition approach that we need to be undertaking more of moving forward. But overall, we did not see an effect for vitamin D on cancer, cardiovascular disease, but yet from VITAL, we have looked at many other endpoints beyond this. These are what we call hybrid clinical trials in which we can look at different outcomes and not just the main ones. For the omega-3 fatty acids, here it was a little bit more of an interesting story. For the primary endpoint of cardiovascular disease, we saw no effect. However, when we looked at total myocardial infarction, we did see that if you're randomized to take omega-3s daily for about 5 years, you had a significant 28% reduction in total MI. And in fact, when you look at some of the other subgroup analyses from the trial, you start to see some other signals for the benefits of omega-3 fatty acids on cardiovascular disease endpoints in particular. So I want to turn attention to the multivitamin and multimineral formulations for a bit. Again, most commonly used supplement in the US, but it's really complicated. There is no one single type of a multivitamin and multimineral formulation. By definition, you have to have at least 3 components in it to be multivitamin or multimineral. But if you go to a store, like whether it's a CVS, Walgreens, Costco, doesn't matter where you go, you are bombarded with options. So this makes it very challenging for anyone to figure out what to buy. And all these formulations have subtle differences, so we don't really know what's the right formulation. And then there's different target, there's the Flintstones for kids, and you've got, formulations for men, for women, for older adults, and then it might be for bone health, eye health, immune function, brain health. You see lots of those. There's something that I would call the Jeopardy effect. I'm not sure how many people watch Jeopardy, maybe. But there's something called Prevagen that's always advertised a lot with the Jeopardy program. And their work is based on one randomized clinical trial that was done about 10 to 15 years ago, very small in scale, and showed some very modest effects. Not sure how clinically relevant they were. But with dietary supplements, it's about advertising, making you believe that they could help without knowing whether they do. And so when we think about recommendations, formulations regarding multivitamins, it's very difficult to do. Now, just to give you a sense of the complexity, some of the trials some of them I'll touch upon, even the nutritional content that differs within these different formulations differs markedly. Even within a specific brand. So in the trials that I've been involved in for about 3 decades now, the Physicians Health Study 2 tested 2 different versions of a Centrum Silver formulation. Even Centrum Silver changes over time. They tweak the nutritional composition of it based on kind of what's hip and what's not. Vitamin D got more popular, they added a little bit more vitamin D. Magnesium seems to be interesting now, so we'll put in a little bit more magnesium. So it's very hard to kind of compare directly. But it reflects just how they approach even these products too. And just to give you a feel of some of these larger trials that have been done on multivitamin, multimineral supplements, this is a French trial that was done several years ago now. It was about 13,000 middle-aged French individuals, and their version of a multivitamin was a little bit more constrained. It was modest amounts of vitamin C, E, beta-carotene, selenium, and zinc. 7.5 years of follow-up, looking at major morbidity and mortality. And it was interesting. So they saw some potential benefits for cancer, particularly in men, and also some suggested benefits on mortality in men. But one of the challenges of testing things like this, it's not like you're testing a new generation GLP-1 receptor agonist where you're testing one specific medication. We don't know what's driving any benefits in a multivitamin because of all the things that are in it. Is it because of a specific component, or is it because of everything in combination? Honestly, if something works, it's probably the most important finding at the end of the day. One of the trials I was involved in was the Physicians Health Study 2. Now, the original Physicians Health Study 1, for those of you that might be aware, was the original forebear of the aspirin trials that was done. So the Physicians Health Study 1 started back in 1982. I was not doing research quite that far back. The Physicians' Health Study 2 began in 1996 and was a large simple trial testing many different formulations, including Centrum Silver, a multivitamin. This trial lasted for 11 years. So this speaks to the value of research and the fact that you have people getting randomized into these trials and not knowing what they're taking for 11 years. What did we find? So we found that those men that were randomized to take a multivitamin versus a placebo actually had a significant 8% reduction in cancer. And if you took out the prostate cancer, because at this point, the trial was done in the early 2000s with the advent, the hipness of the PSA screening, so a lot of prostate cancer that came in was very early stage. And so if you took that out, the effect was stronger. It was about a 12% reduction. And interestingly, the effect was stronger in older men. This study actually got some attention, but there was a lot of skepticism when it came out. There's no way that something as simple as a multivitamin might have an effect on cancer in the way that we found it. No effect, by the way, in cardiovascular disease, just to let you know. So sure enough, of course, one good trial begets another. The cocoa supplement and multivitamin outcome study was another trial that I had initiated with a colleague of mine, Dr. Joanne Manson. This is from about now 10 plus years ago. This was about 21,500 older men and women around the US. I'll touch upon the cocoa flavanols in a short bit, a little bit more briefly, but happy to talk with you more about that apart from the presentation. But we were looking at both cocoa flavanols as well as a multivitamin in what we call a 2x2 factorial trial. This trial only lasted about 3.5 years, looking at major morbidity, mortality, and we have a number of other ancillary studies in there too. So interestingly, we couldn't perfectly replicate what we saw in that Physicians' Health Study 2 in the Cosmos trial in older adults. For cancer, there was no overall effect, although interestingly, if you look in men, we saw a non-significant 6% reduction in total cancer relative to a significant 8% reduction that we saw in the Physicians' Health Study 2 that lasted 3 times longer than what the Cosmos trial had done. And I'll come back to the cancer finding in a moment, a little bit later in this talk. But yet we still saw that there was a significant 38% reduction in lung cancer. Again, when this came out a few years ago, there was a fair amount of skepticism. Again, there's no way dietary supplements can do anything. They're supposed to be a waste of money. You consume it, you take it in, just comes right back out again. One thing that also doesn't come out enough from a lot of the dietary supplement research is potential side effects. It's one thing to focus on clinical efficacy. It's another thing to think about what are the side effects that might come along with taking some of these supplements. I would like to see more of the trials and studies that come out pay more attention to this, because it's not just about benefit, it's about do no harm. And in fact, with the multivitamin intervention, aside from an increase in GI bleeding, which we really had no clear explanation for, there were some things that we saw some lower risks with, whether it be diarrhea, skin rash, stomach upset. So we had a funny dialectic between lower incidence of stomach upset, but yet GI bleeding was a little bit higher too. But at least this provides some important contextual data on what we just don't have for virtually every single supplement that you might buy off of a store shelf. It's not just the clinical outcomes, but understanding whether side effects exist. I want to pivot just for a bit on this concept of aging across the life course, and we think about cognition. Cognition is increasingly appreciated as having vascular origins to it. And of course, there's a large spate of Alzheimer's disease, dementia research that's been coming through appreciating the vascular underpinnings of these outcomes. And so one of the nice parts about the Cosmos trial is that we're able to look at these curves of aging over time through some studies I'll show you to understand, can supplements have a role in the context of what we would call, I'm not sure what's normal anymore as I get older, but normal age-related cognitive decline relative to mild cognitive impairment and dementia. So what's neat about these larger trials is that we embed these smaller trials within it. So the overall Cosmos trial is about 21,500 participants, but we had more than 2,000 participants complete telephone-based cognitive assessments. And what we found is that over 3 years of cognitive assessments, that if you take a daily multivitamin, it slows cognitive aging by about 1.8 years, or about 60%. Quite profound. Now, Does that mean I'm memorizing twice as many words or I notice the difference? That still is one of the disconnects with cognitive research. You'll see effects, but how does that translate to how I might feel or notice a difference? It's a little bit different. It's one thing to say I'm preventing a heart attack. It's another thing to say I'm improving my cognition through different domains. But what was interesting in Cosmos is that we started to find consistent effects across other sub-studies testing cognition in different ways. The aforementioned slide was using a telephone call. We would call participants, about a half-an-hour interview, memorizing lists of animals and recalling lists and numbers and things like that. We also did a web-based cognitive assessment in about 3,500 or so participants at multiple time points, and found once again that if you took a daily multivitamin, it improved memory performance versus placebo to the equivalent of about 3 years of age-related memory change. And then finally, we had a clinic component to these trials. These trials are unique in that we're sending pills out around the country. So whether you're in Redding, California, Tampa, Florida, San Diego, up in who knows where in Maine, anyone can participate in these studies. They're mail-based interventions. They're remotely driven. But we still had a clinic component because we understand and value the importance of those assessments. And there, for those, we had a subset of 600 patients that came in at baseline and again at 2 years. We again found consistency of taking a daily multivitamin and improving cognition. And so when we put these data together in what we call a meta-analysis, you're combining studies from different trials, we found that basically if you take a multivitamin for a few years, you're going to have that much less cognitive aging over time. So this is one clinical outcome we feel quite strongly about, that taking a daily multivitamin might improve cognition, at least in older adults. How does this apply to those of us in our 20s, 30s, 40s, 50s? We don't know. We need to figure that out. Another concept that's out there is this concept of what we can call biological aging. One of the other neat things is you'll see in the Cosmos trials that we've collected biospecimens. I'm very interested in biomarker research as well, both in the context of cardiovascular disease and in the aging space. And so there's been a lot more talk these days about not just chronological age. So I might be 54 years old, great, but can we somehow capture what my biological age? Am I 54 but I'm more like 70? Or am I 54 more like 30? And there's a lot of tools out there that patients and the public are using that are gimmicky, honestly. They're expensive, and they're not necessarily informative because it's not really getting at the roots, which is what are your risk factors and what we know is tried and true. That being said, we know that there are ways that we can capture the biological aging process. And this is usually through a number of different biological age estimators. There's things like proteomics, metabolomics, methylation and epigenetics is one area that we have been particularly focused upon over the last several years. Epigenetics is interesting in that, of course, we all have genes, and we have what we call DNA methylation. So there are ways that we can regulate gene expression over the lifetime. And so we can capture changes in what we call epigenetics to see how many of these genes are being turned on and off over the course of time. And we can generate what we call these epigenetic clocks. These are ways that we can capture kind of how our clocks individually are ticking, for lack of a better word. This isn't meant to be like a ticking time bomb, but rather just how are we doing relative to our age? Are we aging biologically faster or slower relative to what our age currently is? And so in Cosmos, we had about 1,000 participants that provided bloods at baseline, 1 year and 2 years, and we looked at the effects of both the randomized multivitamin as well as the cocoa extract interventions on these changes in the clocks. And this came out just a few months ago in Nature Medicine and got much more attention than I would have expected at the time, but it basically had shown that if you take a daily multivitamin, it might slow biological aging. But here again lies the problem, no different than cognition. These are real findings, they're statistically significant, great, but how does it mean? How am I going to feel? Am I going to feel better? Am I going to feel more energetic? Am I sleeping better? Is my quality of life better? This is the area of the space of biological aging that is still a bit of a uncertainty. We don't know how to translate that into real changes in functional status. And this is true not just for a multivitamin, but for other types of dietary supplements. So I do want to talk a little bit about cocoa. Cosmos was not a chocolate trial, and that disappointed many, many, many participants that we reached out to be clear. Why are you sending me pills and not chocolate bars? In fact, when we think about cocoa, I mean, cocoa as a supplement, shall I say, is really very ambiguous. What people don't appreciate is that even though you might be buying darker chocolate off of a store shelf, that doesn't necessarily mean it has what's in the cacao bean that we think actually might be deriving health benefits, especially in the area of cardiovascular disease. And these are what we call cocoa flavanols. Now, you'll find flavanols not just in cocoa beans, but also in things like berries and tea and other plant-based foods. That being said, what we sought to do in the Cosmos trial was to test not chocolate, but to focus on an extract of the cacao bean, focusing on the bioactive components in it. So when we looked in the Cosmos trial, when we looked at what we call, thinking back to the efficacy versus effectiveness for a moment, when we looked at intention to treat analyses in the Cosmos trial, looking at total cardiovascular disease as our endpoint, it was a 10% reduction in total cardiovascular disease, but it was just off in terms of statistical significance. Welcome to the world as a clinical trialist. That being said, when we start looking at other outcomes, there were some very, very interesting signals. Virtually all of these little squares that you see are to the left of that line, which is of course indicating benefit, so that's a good sign. We also see that for cardiovascular disease death, those that were taking 500 milligrams a day of cocoa flavanols versus a placebo had a 27% reduction in cardiovascular disease death. This is starting to approach kind of pharmacologic levels of benefit here. Furthermore, if we had used a much more refined or streamlined traditional endpoint that we see in cardiology for major adverse cardiovascular events, non-fatal MI, non-fatal stroke, CVD death, there was a significant 16% reduction relative to placebo. Furthermore, if we decided to go the route of what we call per protocol analyses, looking at effectiveness, if we just looked at the people who are taking it as opposed to this kind of once randomized, always analyzed approach, we saw that the effects were even stronger. So does this prove it, that everyone should be running and taking a cocoa extract supplement per se? No. But we actually find this to be tantalizingly interesting, and we're hoping to find, and we're actually hoping to initiate a reproducibility, a replication trial on this to really try to confirm these results. But appreciating the complexity of, this is not about eating chocolate, because a dark chocolate, just because it's bitter, doesn't mean it has the flavanols. Processing it, like any other food, the more you start to process it, the more you start to rip away the natural structures of the food, the coffee bean, the cacao bean, and other fruits and vegetables. But in fact, I think there is mounting evidence, and we're going to see this more moving forward in the dietary supplement space about, can we think about dietary guidelines that extend to bioactives, some of the things that are not essential vitamins and minerals? Can we find an appropriate evidence base from clinical trials, and not a lot of smaller ones, that can show definitively that these things either work? Honestly, if they don't work, that to me is just as informative. I do want to add some comments on herbal supplements. We've been talking a lot about kind of essential vitamins and minerals and some of these bioactives, but about 20% of US adults are also using herbal supplements. This is an even more ambiguous area in terms of research and evidence base. And I don't say that because they don't work, but I think there's a simple response of, we just don't know. And again, if you're more healthy, we see more use, no differently than if you have a lot more unhealthy factors or other conditions, you tend to be users too. It's almost like a U-shaped curve of sorts. But there are many types of herbal supplements that are commonly used. Garlic, ginkgo, echinacea, cotton, and these are just a few. I mean, I'm sure many of you can think of many others that either you're taking or you see among your patient populations. But the clinical trial evidence on these is particularly problematic. There's smaller trials. Now, it's not that smaller trials are bad. They're still equally informative, but you're not going to get the type of definitive answers that you would get from trying to do the larger trials, which are rarely undertaken. And furthermore, when we think of meta-analyzing or combining these studies together, these also tend to get a fair amount of the media bites out there too. Just because you're combining the studies together doesn't necessarily mean it's giving you stronger evidence. So whether you're looking at garlic and C-reactive protein, a marker of inflammation, looking at curcumin and BMI, or looking at adiposity, just because you're seeing evidence that's pointing in the right direction doesn't mean it's necessarily working, nor is it, think about it, right? These are all testing different formulations, different patient populations. It's very hard to put all those data together in a fundamental way. Just as a case in point, this is a trial that came out, it's a neat trial that came out a few years ago, just looking at the effects of rosuvastatin versus placebo, but then looking at all these other kind of non-traditional remedies that have been purported to lower lipids. And we saw quite convincingly that, you know what, sometimes you just got to stick with what we know is tried and true. What's been interesting is through all of this data I've been throwing at you at an early hour, dietary supplement recommendations have been incredibly static, I would say. If you look at the dietary guidelines for Americans, at least for the previous 2 iterations, the focus was correctly on food and dietary patterns and nutrient-dense foods. That is always where prevention starts across the lifetime. I'm not pro-supplement, I'm not anti-supplement. We need to know what these supplements are doing in the first place before we can make that determination. There's been a focus as time has gone on about, well, maybe we can think about nutritional needs beyond the foods. And in fact, with the dietary guidelines for Americans that just came out earlier this year, as many of you may be aware, this is a very atypical process. I had several colleagues of mine that were on the committee for this, and basically the rug was pulled out, and they came up with a much more simplified version of the dietary guidelines for Americans. Now, that being said, one of the things that got introduced for the first time, which is not a bad thing, is that they're recognizing that dietary supplements might be a tool to help address nutrient gaps for certain segments of the population. I mean, that is inherently a true statement. The question is, how do we really go about evaluating that in a way that it's good-based, rigorous science that's backed behind that? And I think that's where our challenge is, given the Deshays Act and how we regulate dietary supplements, as well as how do we implement that. If you also look at the Academy of Nutrition and Dietetics, one side would, any dietetics, any nutritionists in the room? We need to get more of those people into the room, for lack of a better word, especially when we're thinking about in the context of cardiovascular disease prevention and integrative health. There's a recommendation that everyone recognizes the fact that, you know, we need different nutrition, we have different nutritional needs across the lifetime. How do we address that? We know for prenatal vitamins that there's a real role there with folic acid. And there was other parts of, you know, vitamin B12 deficiency in older adults is a real thing. How do we address that more fundamentally? But we need to bring the nutrition community into the prevention efforts that we take. There's something that we call the U.S. Preventive Services Task Force. I'm not going to get into all the details on it, but they kind of meet every so often. Our joke, at least for us internally in Boston, is that they tend to meet after we've published our larger trials, because they say, oh, we've got another big trial, we need to think about how to summarize this. They consistently like to say that there's really no evidence for taking dietary supplements, at least for cancer, cardiovascular disease, and mortality. But it's a gross oversimplification of their effort, given the fact that we know that these things are not just used for those 3 outcomes. In fact, what's interesting is in their last set of recommendations from a few years back, you know, they typically do, again, they combine the studies and trials and they report on that. It's kind of silly to me because when you look at the multivitamin finding, the 3rd row down in this table, it shows quite convincingly that if you look at the effect of a multivitamin on any cancer, there is a significant 7% reduction in any cancer. Didn't highlight it, didn't emphasize it, didn't recommend it. I'm not saying that they should have recommended it, but at the same time there is almost, it's kind of like, we're just going to tuck this away. If I knew that we had an intervention that could reduce cancer, total cancer mind you, by 5, 6, 7%, knowing how common it is, I don't know why we wouldn't be thinking about that, at least having a broader conversation about it. They do address a lot of issues regarding safety and generalizability. This is something that's kind of the unspoken piece of dietary supplements. A lot of the supplements have different labels on it to help indicate that they've at least gone through some degrees of safety standards. But honestly, from a consumer standpoint, unless you're really well informed, you're not going to really know what those things mean. We also hear in the news all the time about what we call adulteration of dietary supplements. So things are in it that were not supposed to be in it, or it wasn't what the labels said they were. These are real issues that need to be much better addressed than what the current DSHEA guidance oversees, or at least mandates. And so the recommendations that come out never address safety and quality standards for supplements in the way that we should. People have to be able to trust what they're taking. And the further you get away from the big brands, so to speak, even the larger generic brands, there isn't necessarily certainty about what's in it. And typically, just so you know, if you're buying, say, a vitamin D supplement that lists as having 1,000 IUs per day, 1,000 IUs in a pill, what that usually means, not surprisingly, there's probably about 1,100 or 1,200 IUs in it, and the idea is that over the course of a year, it's going to steadily decrease a little bit. Now, does that matter a huge amount? Probably not, but for things we know less about, we might be more concerned. So, from my own perspective, over the last few decades, when I'm dealing with these large trials of dietary supplements, it's kind of a no-win proposition, because if I get a trial result that shows that something works, everyone quickly says, we knew this all along. You tested the right thing, this is the right amount, you did a trial, you had the right endpoints, great. Get a quick pat in the back, you move on. If you get a null result or even a harmful result, it's amazing how quickly the criticism piles on. And I've seen it from both sides over the years. You tested the wrong supplement, the wrong amount, wrong patient population, et cetera. So you're really kind of, it's a no-win situation, at least from the trialist standpoint. And I think this would apply to many others who have been doing this work over the years in trials in general. But I think this is what we need to see more of is research. It's as simple as that. Better trials, more innovative designs. I have a much greater appreciation over the years for the importance of the design of the trial and not just the outcome, and also making sure that you have the right population that's represented. And so that when the patient's coming in with that proverbial brown bag, it would be nicer for all of us to know exactly how to comment on it, not just what you're taking, but honestly just to ask, wait, why are you taking that? What's the motivation behind it? Because there's a fascination psychology behind taking dietary supplements in particular. I'll start taking something, I didn't drop down and die within a week or two, so I guess that's good. I think I'm doing better. There is a placebo effect, that's a very real thing. So, but is it really deriving the health benefits? And I think this is where we need to really continue to think through this more carefully, collectively. So with that, thank you for your attention, and I'm happy to take any questions. So.
Questions? Okay.
I guess multivitamin sales are going to go up in Reading.
Well, I can, so yes, the question was again, will the multivitamin sales go up? Should they or shouldn't they? I mean, honestly, I mean, we've seen the trials that we've been involved in have focused on older adults, 60 and 65, and men 60 and up, women 65 and up. I mean, I would like to see these trials reproduced in some way. Again, we don't know whether the benefits apply to who and whom, and what we just don't know is, should we be assessing nutritional status before someone takes a multivitamin in the first place to understand whether you're going to be better or more likely to benefit from taking, whether it be a multivitamin or something else. So I'm not a big fan necessarily going out to the store and taking more dietary supplements. I think there is a lot of money wasted on it. You get some of these products that are very expensive relative to budgets and other things I'd rather see people putting their money into, like go to a gym, just do something, get active, right? The idea of popping a pill is a very palatable solution. It's an easier solution, but that's not necessarily the right one.
Two quick questions for you. Vitamin D and osteoporosis, is any truth to that? Number two, you mentioned that multivitamin minerals slows down cognitive decline. If so, what kind of multivitamin minerals brand do you recommend?
Yeah. So for vitamin D and osteoporosis, there is, I would say, very limited evidence on whether vitamin D on its own will really lower the risk or improve the trajectories of it. It's not just vitamin D, it's calcium. and other nutrients. It's also diet, and there's a greater appreciation, no different than if you, if you have a revascularization procedure nowadays versus 3 decades ago when you're told to basically be sedentary for 3 or 4 weeks. Now it's like the more you move, the better off you are. So it's no different than osteoporosis in that regard. As for specific brands with a multivitamin in the context of cognition, I mean, the only thing that I can say is like our trials have been only based on Centrum Silver. That doesn't necessarily mean that Centrum Silver is the answer. And one of the kind of unknown questions, and I get this all the time, is, well, what is it in the multivitamin that's creating the benefit? And if this side is like the vitamin D camp, they're going to say, it's vitamin D. I knew it was. It had to be the vitamin D because there's 1,000 IUs. Whereas on this side, if they're the magnesium camp, they're going to be like, it's the magnesium. I told you so. It probably doesn't matter what it is, honestly. If it works, it works. And to that effect, whether it's Centrum Silver or another major brand, doesn't even have to be a brand, it could even be a generic, it's probably more, for me, it's something more about the natural interactions of the essential vitamins and minerals in combination. This is not about megadosing. This is just about putting everything together and working together. That being said, when you're taking supplements, by and large, there are, very basic, there are water-soluble and fat-soluble vitamins. So it's always important to have it with not just water, but with some food. So that will at least help improve the absorption without it just getting peed out or otherwise.
Doctor, you had a picture there with rosuvastatin, a lot of improvement, let's say, in lipids or cardiovascular disease reduction. Then you had other fruits and other elements in our diet that had smaller amounts. Would those be accumulative or cumulative versus the rosuvastatin? Let's say you eat more strawberries and beans and lentils. Would those together have the same beneficial effect as the rosuvastatin?
Yeah, so the slide you're alluding to is it shows how taking the rosuvastatin over a period of time obviously not surprisingly, lowers lipids, the LDL, by 35, 40%, as opposed to the red yeast rice and some of these other kind of more random herbal and other alternative remedies having either no effect or a very modest effect. We know that from dietary intervention trials that have been done, focused on the diet and not just individual supplements, that, for example, the DASH diet is a very nice example of that. We know the DASH diet, as old and tried and true as it is tried and true. So will it give you the same level, of course, of improvement in your lipid profiles as it would perhaps taking rosuvastatin or some of the other lipid-lowering medications? No, but it should be all done in concert in combination. And we've seen time and time again from randomized clinical trials that the more that we're integrating lifestyle along with the pharmacologic interventions that we know do work from the trials that we've done, that it tends to enhance the benefits, not just for lipids, but for the subsequent cardiovascular and other related outcomes.
I have a comment to make. So you touched upon vascular proliferation to the brain to help reduce dementia. On the internet, social media, there's a big pushback against statin medications. And just the opposite, and this is what I teach all my patients, the opposite was actually found in trials, that the p-value of the atorvastatin missed it only by a little bit when they looked at tens of thousands of people, found that dementia reduction was found with the use of statin medications. So I really encourage people to push statin medications for the prevention of dementia versus other treatments and what people come in and tell us not to use statin for.
Yeah, no, I appreciate that. I mean, I think we've seen, a lot of times it's termed pleiotropic effects, like, oh, these are things that we don't think are related, but, we see that there are benefits for it. But especially appreciating the vascular underpinnings of brain health and biology. I think these are patterns that we're seeing more and more, that for the various statins, and there's been questions that have been raised regarding GLP-1 receptor agonists as well. Like, what are some of these other effects that might extend beyond just weight loss? And it's not that simple. But that being said, I think while it certainly draws more attention to some of the benefits of the existing medications that are the tools in our proverbial belt, but appreciating its connectivity with lifestyle and prevention. And those are ways that we can enhance those benefits even further. So I appreciate your calling that out.
Yes, sir. I'd like to just kind of continue Dr. Solkowitz's question, but as a cardiovascular provider, I come up against a huge pushback against certain pharmaceuticals. However, when you look at their med list, they are taking 20 plus supplements, but they don't want to take this pill. So I kind of want to know what your stance is on that. How do you convince a patient that maybe they need this medicine along with their supplements in conjunction?
Yeah. It's difficult. I don't know how else to say it. You have a very strong, a much larger segment of the population that are not just taking a few, but as you correctly point out, dozens of supplements, powders. Protein powders are all the rage again, somehow or another, without really knowing what those benefits are. Again, the interactions with things. But it gets away from the basics, which I think you correctly point out, which is that we know certain medications simply work. And I think in my own experience with different groups and discussions I've had, the more and more that you can try and emphasize that just taking one other pill in combination with the things that you're taking is at least a step in the right direction. That being said, the hard part is that we know so little about how all of these different supplements in different forms interact not just with, say, statins or other things, but also with each other. That there's usually more harm that's being done than good when you're over-supplementing in whatever way that you are. But that's a difficult message to come across, especially in the political climate that we're in. On many levels, I would say that the MAHA movement in intent is a wonderful idea. We need to make America healthy again, no doubt. The question is how and what do we emphasize? And that's where the debate continues to rage.
Another question back here.
The studies on longevity and quality of life are an important aspect of studies in this spectrum that we talked about. Did you try to correlate them with things like resveratrol, metformin, and nicotinamide? David Sinclair from Harvard, and they have these catchy things like food as medicine, eat to beat disease. So I think that would become a part of the spectrum. Thank you.
Yeah, it's a very good question. There's many different interventions you rolled into that in the context of longevity. Certainly metformin, something I have a little bit more faith in. Resveratrol has been talked and bantered about for a long time with virtually no clinical trial evidence to show whether it does anything. It's really more about, to me, thus far, supplement sales for about 2 decades on that front. I do appreciate your reference to the food as medicine and culinary medicine and teaching kitchens. These are ways more recently over the last decade or so, there's been much broader efforts to not just get people to eat better, but to understand how to make food and bring people in from the community into a situation where everyone can cook together and socialize and understand how do you make good choices, how do you work. Because culinary skills are quite variable. Whereas I cook most of the time at my own house, and we try and impart that on our kids. One child is always experimenting and sending pictures of what they've tried to create. The other, no interest. But trying to get that as part of the cultural effect, I think, can go a long way when we're thinking about it in the context of longevity in particular. So I appreciate that point. And my work with the Osher Center for Integrative Health actually is starting to focus upon teaching kitchens, culinary medicine as tools to help enhance not just cardiovascular disease health, but other forms of health too.
One of your slides talked about the side effects, GI bleeding and bruising and stuff. Do you think the mechanism of action is antiplatelet or anticoagulant on that slide that you presented?
Yeah, it might be antiplatelet, anticoagulant in the context of a multivitamin. The problem is that we think it's probably not because the amounts of, say, vitamin E or some of the other vitamins and minerals that might be responsible for that, they're so low relative to the other types of higher dose supplement trials that have been done that we think it's just coincidental. You know, the reality is that when you have a list of 20 potential side effects, by chance alone, one or two of those are going to work out in one direction or another, and we'll just call those false positives in some capacity. We haven't seen, and actually that finding that I showed in the Cosmos trial was not shown in the Physician's Health Study too, so I didn't have that slide up. So it wasn't as if we saw it both times. Interestingly, in the Cosmos trial, when we looked at the cocoa extract intervention, we had seen that those that were taking cocoa extract actually had a lower incidence of headaches and migraine. And so, which kind of makes sense when you think about cocoa in the context of its theobromine content. It's a mild stimulant, similar to caffeine. And so that actually spurned a separate trial that's now underway, looking to see whether if you take cocoa, that might have improvements in migraine frequency and things like that too.
I was curious about CoQ10, turmeric, and glucosamine in relation to all that.
Yeah, turmeric is still very much understudied. I'll leave it at that. There's been a lot of smaller trials with regard to turmeric and or curcumin for that matter, and they love to promote its anti-inflammatory properties in particular. Couldn't tell you what that translates to in terms of clinical effects. And there's wide variability in the types of curcumin products that are out there on the market. So that's a huge issue. So these are the examples of supplements that you get a lot of stuff flashing out at you on social media, on the web, commercials, but I tend to say take a pass on those if you could. CoQ10 is interesting in particular. CoQ10, of course, has been seen on many levels as something that goes along with statin use to help with avoiding some of the muscle issues that could come up. And there's pretty good evidence behind that, but at the same time, CoQ10 is quite expensive. If you haven't realized, if you go to the store and you look to see what the CoQ10 prices are, it's expensive. And is it necessary? Is still a definitive CoQ10 trial, even in the context of statin use, with or without it, hasn't really been done as well as it should be. CoQ10 has also been purported to have lots of other effects beyond just kind of focusing on muscle, shall we say. But if you really think about it, for most of the supplement companies, and this is, I think, appropriately critical, if you had the decision to spend, let's say, $1 million on a research study, a clinical trial, versus conducting or just doing more advertising, which one's going to give you more revenue? It's the advertising. And because of Deshays and how it's structured, you don't have those requirements to demonstrate efficacy in the same way as a drug that you're going to prescribe. So it really puts us in a very strange position as healthcare providers in terms of how to convey that information and decisions that would be made by patients either on their own or talking with them.
When it comes to vitamin D, you mentioned that was a thing of the 2000s, and I felt like we were testing everybody and correcting it all, and then the pendulum swang, and it's like maybe it's just an indicator of problems. What do you think? Should we be testing it? Should we be getting everybody up to 30 and above?
Yeah, I think it depends who you ask. In my own opinion, regarding the vitamin D question, do you get over 30 or whatever threshold you believe in? There's probably no harm in at least testing on 25-hydroxy-D just to see if you are ridiculously low, right? I think if you're particularly low, there's probably some merit there. That's clearly an indicator of something. Does that mean you should start getting, should you start to supplement per se? Maybe that's an indication you should think about it. Of course, there's a few different ways it could be approached. But as a marker of health status or health risk, I think the debate is still out there. In the VITAL trial, I didn't have the time or the wherewithal to go in much deeper detail. One of the nice parts about the trials that we've been fortunate to undertake is that we call these, we kind of deem them hybrid randomized clinical trials in that we might be focused on cardiovascular disease and cancer and other major morbidity and things like death over the span of a long period of time, but we're collecting data that allow us to look more deeply into the mechanisms and other outcomes that might be relevant. And so, but again, a dietary supplement is not going to be good for everything, no different than anything else. So should we test? It might be good to get one evaluation at some point, but to start measuring it serially, I'm not really sure what that accomplishes. And we don't know what those health effects are. What are the benefits of actually supplementing? The evidence is not clear for vitamin D. So I would say it's a coin flip whether it's really necessary.
So even if it's below 20, below 10?
Yeah, I mean, first of all, you have to figure out whether someone is below 10 or 20 or 30 for that matter. So I think in that regard, having at least one screening at some point just to evaluate what vitamin D status is looking like probably has utility. But you'd be surprised how many times I get contacted from whether it be media with questions or participants or patients saying, I'm measuring it 6 times a year because I'm really fanatical about making sure it's above a certain threshold. It's distracting from some of the things that we should be focusing upon. So it's a marker that I think could be evaluated at one point in time and you can act on it, but I wouldn't go deeper than that really. Got biased toward this side of the room a little bit more with the questions, although I appreciate this side.
I have a question. Do you have any recommendations, dietary-wise, on the patients with the chronic migraine headaches? Any foods to avoid or any foods to recommend?
Yeah, so I can't claim to have the level of expertise specific to migraine. There's a colleague of mine that's with me in the Division of Preventive Medicine that's much more active than I am in the migraine space. What we've seen with migraine is that a lot of times, we often are recommending to reduce caffeine consumption, although there's some debates about whether that increases or decreases risk of migraines or severity. But what we've seen with migraine, by and large, is similar to some of the other, let's say, vascular or cerebrovascular outcomes, is that usually it starts with a good diet. And a lot of times migraineurs are asked to keep logs, diaries of what you're eating and other things that you're doing that might be leading to, and trying to understand what those triggers are short-term and long-term. But it still starts, to me, like anything else before supplements in any way, shape, or form, starts with a good, healthy diet and a good lifestyle. I mean, that's always the first line of defense.
I had a question about lion's mane, in particular about mushrooms, and what are your thoughts on supplements? That's kind of a big topic right now.
Yeah, I honestly don't know a lot about it, so it's going to be hard to give you a lot of concrete information, but it's another good example, and it's actually not, think about the psychedelics is another good example too. We know very little. We might know how it feels, or the short-term responses that we might have, whether it's mushrooms or otherwise. What we know very little about is how that might be interacting in the face of, if you've got a cardiovascular disease patient in front of you with a history of X, Y, and Z, how is that going to interact with medications that they're hopefully taking? Again, these are not meant to be substitutes for standard of care. And so the question is, these are deemed dietary or food supplements. And so the question is, how do those supplements factor in with what they're taking? So I don't have as much information to give on that, but it's another good illustrative case of being very mindful of exactly how that's fitting in to standard of care or what that patient's getting.
In the interest of time, we have to move on. I promised somebody I'll ask, because they asked me to ask you about liquid IVs. It's becoming very popular.
Yeah, I think this is the challenge of doing supplement research for myself over the last few decades, is that just when you think you've covered all the bases, something else emerges. So you see ID, like the IVs for like NAD and some of the other things out there too. It's another case of, you take it, you might feel good. Actually, I've heard many people say they don't feel good after it, but somehow that's part of the process, that if you don't feel good, it's working. Again, there's a fascinating psychology of dietary supplements, no different than other integrative health approaches, that gets factored into this. If it couldn't, it's the classic case of it, if it's not hurting me, then it might be helping me. And I think the IVs are another good example of that. It's trendy. There's a lot of interest, and again, rightfully so, there's a lot more interest in using dietary supplements to improve health. And I would say that even younger adults are more interested in improving health over their lifetime, which is great. We should have been thinking about this decades ago, probably centuries ago. The whole key is, what are the modalities that actually work? The hard part is having some data that we can attach to help support that.
Thank you.
Thank you.